Hello and welcome to the Unit 9 lecture on mobility for nursing fundamentals. These are your learning objectives. Please review them in anticipation for class and for prep for the exam. So we'll start with a basic review of structure and function. Bones are the framework of the body and they protect the organs. Muscles, they get things done. They can hypertrophy, which means they get larger with movement, or they can atrophy, which means they waste away from disuse. And then our joints are able to perform various motions, such as abduction, adduction, flexion, and extension. Objective G asks us to describe proper body mechanics to use when positioning, moving, lifting, and ambulating a patient. Well, we want to prevent injuries to ourselves and use available resources to make transfers easier. So if we can take the 4 points listed on this slide and apply them to our daily work, that's going to make things a lot better for us and it's going to reduce the risk of injury in our jobs. Aerobic exercise is vigorous continuous movement. Aerobic exercise depends on oxygen. Examples include walking, spinning, and running. Aerobic exercise can become anaerobic, though, if we perform it at a level of intensity that's too high. So anaerobic exercise includes things like endurance exercise, such as maybe if you run a little bit too long, or cycling a little bit too long. Anaerobic means without oxygen. An anaerobic exercise consists of brief, intense bursts of physical activity. So more examples would be like weightlifting and sprints where oxygen demand surpasses oxygen supply. While aerobic exercise relies on oxygen, anaerobic exercise is fueled by energy stored in your muscles through a process called glycolysis. Glycolysis is a method where glycogen is broken down into glucose, which is known as sugar, and then it's converted into energy. So anaerobic exercise then by that process helps us to build lean muscle mass. So it's not all in all a bad thing. Isotonic exercises include activities of daily living. These are things like walking, climbing the stairs, and gardening. It involves isotonic movements, which include stretching, reaching, or bending. So an isotonic contraction is any contraction where a muscle shortens to overcome resistance. When a muscle shortens, at least one joint moves and the body movement occurs. Isometric exercise, on the other hand, includes things like planks or wall presses, and this is a way to build strength in muscle through a static hold. So with isometric muscle contractions, there is not any movement involved. It occurs when your muscles push against a fixed resistance and no joint or body movement goes on. Range of motion can be passive, which is performed by staff to prevent contractures, or it can be active. This is purposeful exercise that's performed by the patient, and it's meant to strengthen and prevent stiffness. Normal gait, we want to look at this, and we should assess the patient's abilities before planning activities, because this allows us to plan appropriate interventions for the patient. Exercise and proper nutrition are essential for health promotion and disease prevention. When we assess our patients, consider the patient's lifestyle. Do they exercise routinely? Keep in mind that exercising increases muscle tone and muscle strength, so it is important. Consider diseases that might affect the nervous system. So for example, Parkinson's limits mobility over time. A spinal cord injury could result in paraplegia or inability to move the legs, and this could happen quite quickly. Muscles need oxygen, which is supplied by the body's ability to circulate blood through the body. Energy comes from the breakdown of food, and this is called metabolism. We want to assess for congenital problems like bone and joint deformities. An example that you might be familiar with is scoliosis, and this is that curvature of the spine. We want to look at how does it affect the patient's ability to perform ADLs. Another consideration is fear of pain or ineffective coping. An example of ineffective coping could be the patient that recently became a paraplegic following a spinal injury. This is a total lifestyle change for this patient, and they may not deal with it very well at first. Imagine for that patient, the change in lifestyle, family relationships, financial stressors, and ability to navigate at home, just to mention a couple of them. We want to assess for treatments like casts or braces. Bed rest can be considered a treatment for those who need to limit movement. Not for everybody though. So examples of patients who might need bed rest would be patients who are weak, but keep in mind that bed rest increases weakness over time. Also patients who might be in pain related to immediate post-op surgery or injury, or those with a DVT or deep vein thrombosis. These patients are going to be on bed rest because this helps to prevent the clot from moving. So that would be appropriate for that patient population. As part of the basic skills head to toe, you assess circulation in the lower extremities, assessing for DVTs, and part of the things that we could do for these patients would be apply TED hose to keep the blood flowing back to the heart to prevent the venous stasis. So what will the nurse be looking for to assess problems with the patient's abilities to be active? Well, the term flaccid refers to decreased muscle tone. This is seen with stroke. Spastic refers to increased muscle tone. This is seen with diseases like multiple sclerosis. Symptoms include stiffness and spasms of the muscle. When assessing for altered gait, the nurse looks for lack of coordination in muscle movements called ataxia. Does the patient lose their balance or have poor coordinated movements? Well, that information can be assessed during the neurological assessments. Recall that the various neurotests you learned in basic skills include things like the gait test. We have the client walk across a room from heel to toe. The Romberg test, where the patient closes their eyes with their arms at their sides. And if you recall, loss of balance is abnormal, and this indicates a likely neurological disorder for balancing. And then we've got pronator drift, and this is where we extend our arms up to eye level, palm up, and close our eyes, and we're looking for the patient to drop their arm down to their side, and this can be seen oftentimes with stroke patients as well. We want to assess for risk for falls. Again, any patient in an unfamiliar environment is at risk for falls. And then we want to realize that joints stiffen rapidly if we don't use them. These are called contractures. So because of this, it's very important to have the patient perform active range of motion or have the staff perform passive range of motion to prevent these contractures from occurring. Now, if the patient's in pain, either chronic or acute, their ability to be active is going to be limited. So we need to think of some creative ways to keep them mobile and flexible. So what type of problems place a patient at risk for activity intolerance, do you think? Well, a few examples would be shortness of breath, weakness, and fatigue. And activity intolerance is just the inability to do the activity because maybe they get dizzy or have a drop in blood pressure, they might get diaphoretic, any of those kind of symptoms. So if muscles are atrophied and the patient's ability to tolerate exercises is greatly reduced, then we have a problem, right? Contractures can happen, and like I said, they can be irreversible and they can cause disfigurement. An example of this is foot drop, which is where the patient maybe is laying in bed and their toes are kind of pointed down towards the end of the bed and their ankles are never, they never get range of motion. And that results in the patient permanently having their toes pointed down. So then when they get up and try to walk around again, it's going to be difficult for them because their foot doesn't move the way it's supposed to anymore. When the patient changes position normally, we do not see a change in blood pressure or heart rate when the patient's laying flat. Okay, so then when the position changes and they suddenly sit up or stand, there could be a drop in blood pressure or heart rate. We want to assess for this drop by performing orthostatic blood pressures, and this is checking the blood pressure lying, sitting, and then again when the patient's standing. A change of a drop in a blood pressure or a change of an increase in a heart rate is a problem with the orthostatic hypotension assessment. If a patient has a DVT, they're non-weight bearing. We don't want the blood clot to break loose and travel to the brain, lungs, or heart. The lungs could be underinflated when the patient's immobile, and this places a patient at increased risk for atelectasis. This is lung collapse where the alveoli get clogged with mucus and then can't open and take on oxygen. This puts the patient at risk for pneumonia. A decrease in metabolism affects hormone production and protein breakdown. So for example, more insulin is needed for immobilization. Also the kidneys are affected. The BUN, or the blood urea nitrogen, is a blood test to determine kidney function. The kidney is affected because the breakdown of protein through immobility is then excreted as nitrogen through the kidneys, and so then we get that elevated BUN. The patient could lose their appetite, and this is called anorexia. Immunity could be impaired because there's a decrease in circulating antibodies in the bloodstream. We could get pressure ulcers or pressure injuries over bony prominences because of decreased blood flow to those areas, as well as the patient with immobility being less able to reposition themselves, so they're just kind of stuck there. We need to be diligent, frequently repositioning these patients to prevent skin breakdown for this reason. They could have urinary problems. So urinary problems could occur because of difficulty voiding when laying flat. There's also a chronic delay in emptying, which can contribute to urinary tract infections. And why is there a chronic delay in urinating when immobile? Well, no one answers the call light when they need to. It hurts to move, so the patient delays moving around. So they just sit there and they hold it. Constipation occurs because there's a decrease in peristalsis with immobility. And then we can have problems sleeping because of a lack of a sense of being tired. They're just laying there all the time and they are not stimulated. And then psychosocial problems include the patient's loss of control over the situation, and then they can have an altered self-concept as well. So let's assess. We always start with assessment. We review all the factors listed on this slide, including the subjective assessment. For the objective assessment, this is a physical assessment. It includes proper alignment in the bed or chair. Notice that guy sitting in his chair bending at the neck, not a good position to be in. Proper positioning helps to promote sleep and also positively affects muscle tone and overall well-being. We want the patient's spine and body parts in correct alignment. This means if they're slumped over in the bed or the chair, help them sit up straight. If they slid down in bed and are bending at the chest when we put the head of the bed up, they need to be moved up in bed so they can bend at the waist. This helps prevent unnecessary pain and discomfort. Think about how you feel in the morning when you've slept wrong and your neck gets out of alignment. It is a setup for a bad day. You can look at your text, I believe it's table 22.4, for a list of NANDA diagnosis involving mobility. And this list just shows you some related factors and outcomes and interventions for selected nursing diagnoses. So check that out in your text, and that'll give you a little bit more idea about how to work these diagnoses in. So outcome goals are broad, remember. Outcome criteria should be narrowly focused, smart, and patient-specific. And then remember, if we're picking out an outcome criteria, this should match up to the signs and symptoms or the as evidenced by part of the nursing diagnosis. So if you can keep that in mind, it's going to help you pick out the right outcome criteria in relation to the right nursing diagnosis. So what are some appropriate nursing interventions to help with impaired mobility? Well, we want to primarily focus on injury and fall prevention. Check a fall risk assessment and implement fall precautions. We also could include passive or active range of motion and encourage exercise, because these are all going to be important in preventing loss of function. This slide just lists a bunch of terms to know in relation to mobility. You're going to want to know these terms. When Trendelenburg would be used, that's a little controversial, I guess you could say. For the most part, the school of thought is head of bed down if the patient's got a low blood pressure, because that's going to get blood flow to the brain and it's going to perfuse the brain better. So that tends to be the gold standard. However, if you keep a person in Trendelenburg for a long time, it's going to cause problems then when you try to sit them up and get their equilibrium back to baseline. But as a general rule, Trendelenburg would be indicated for a low blood pressure. Know the terms also of adduction, abduction, flexion, and extension. So adduction is movement of a limb towards the midline of the body. Abduction is movement of the limb away from the midline of the body. Flexion then is bending a joint that decreases the angle. So if you bend your arm when you get your blood drawn, that is flexion. And then extension would be a straightening of the joint. So an example would be if you unbend your arm. And there's certain things that we need to take into consideration when we're caring for patients that have certain procedures or certain processes going on. One example is the care of a patient post-hip surgery. So we want to make sure we prevent adduction of the hip and leg. We want to keep the hip flexion more than 90 degrees because we don't want to pop that joint out. And we want to keep the leg in neutral position with toes pointing up. And these interventions are evidence-based, and they focus on preventing dislocation of that new hip joint. So that's just one example there of how we can use these terms for that patient subset. So if a patient gets dizzy or has other signs of activity intolerance, such as diaphoresis, drop in blood pressure, increase in heart rate, significant shortness of breath, stop what you're doing and help them sit down immediately. We don't want them to pass out and fall down, and this can happen pretty quick. Often activity tolerance can be minimized if we just simply put the patient on the edge of the bed, let them sit there and dangle their feet over the edge for a little while before we stand. This allows their body to get used to the change in position gradually and is a way to tolerate or to help them tolerate the activity a little bit better. Transfer aids just help us or help the patient get around. So we want to use teams to lift patients safely. Use stand-up assistance devices. An example that's shown here is the Sarah Steady that's used in a lot of organizations around here. It's important to understand how to use correct body mechanics when positioning, ambulating, and moving patients. So for canes, the patient should hold the cane in the hand opposite the weak leg. For walkers, move the walker forward, then the patient steps up to the walker using the walker for support. Take just a few minutes here and answer these questions. See if you got a handle on how to move people safely, and we will talk about these in class. And then after we're done with our interventions, we want to evaluate. So evaluate for effectiveness. If the goal is the patient will participate in measures to prevent potential complications of immobility, the goal is going to be met if the patient doesn't develop complications of immobility. Simple as that. If something's off with it, then what we want to do is just re-look at each step of the nursing process and kind of see where it went wrong and revise as needed. Thanks for watching, and be sure to check out the presentation on nutrition also. Have a great day.